Good morning. Greetings to all the attendees of this Internal Medicine Summit and the 43rd National Congress of Internal Medicine in Mexico. We present a case in relation to the initial diagnostic approach to mediastinal masses by the Internal Medicine Service. These masses are more frequent in the anterior mediastinum and are mainly of infectious origin or associated with malignancies. The most frequent of the latter are neoplasm of the thymus, thyroid, germ cells, and lymphomas. These lymphomas are characterized by the presence of these symptoms, malignant lymphadenopathy, and elevated levels of LDH, rapid growth, and risk of oncological emergencies. A 31-year-old man with chronic cough of more than a year of evolution, along with progressive dyspnea and previous hospitalization for a pleural effusion, but without a diagnostic protocol. 1 month prior to his admission, the dyspnea increased and he started experiencing systemic symptoms, or B symptoms. On exploration, we find lymphadenopathy of inflammatory characteristics. On the chest X-ray, a mediastinal widening in the laboratories, it calls for attention the normal levels of uric acid and LDH. Other findings were severe anemia and thrombocytopenia. A hematological malignancy is suspected, ruling out infections by serology and cultures. CT scans show multiple lymph nodes conglomerates at the thoracic and abdominal levels, and lung mass dependent of the mediastinal lymph nodes with diffuse enhancement that correlates with lymphoproliferative process, also finding spleen and liver enlargement. A cervical lymph node biopsy is taken that reports a mixed cellularity Hodgkin lymphoma with the classic markers. Looking at the literature, we found that primary mediastinal lymphomas tend to infiltrate the lung, abdominal lymph nodes, and spleen. They usually are diagnosed at advanced stage with systemic symptoms. This case had multiple pulmonary and extrathoracic involvement, so it was classified as stage 4 with a score of 4 in the International Prognostic Index, given the levels of albumin and hemoglobin, the clinical stage, a diagnosis, and the male sex. This represents a 5-year survival without progression of 51% and 61% of general survival with appropriate treatment. An ABVD chemotherapy regimen scheme was started, 6 cycles, 1 every 15 days. The patient did not present signs of obstruction of the superior vena cava or tumor lysis syndrome, neither spontaneous nor treatment associated. No similar cases with normal LDH were found in the literature. We suspect the cause to be a slower growth compared to nodular sclerosis Hodgkin lymphoma. As for the characteristics of the adenopathy, we found this to be more in association with anaplastic cellularity, not Hodgkin lymphomas. Thank you for your attention.